Welcome. Today, we're breaking down a major new meta-analysis. It provides some much-needed clarity on the potential of a non-invasive brain stimulation technique for treating the motor symptoms of Parkinson's disease. First, let's just quickly frame the scale of this challenge. Parkinson's disease is the second most common neurodegenerative disorder on the planet. It affects up to 10 million people, and it progressively impacts their ability to move and their overall quality of life. One of the most difficult hallmark symptoms is something called freezing of gait, or fog. It's this sudden, very distressing inability to move your feet. As you can imagine, this becomes a major cause of falls, and it really compromises a patient's independence. So this brings us to the core question, and to a therapy called repetitive transcranial magnetic stimulation, or rTMS. Let's really dig into what this is and what the study found. The way this works is actually pretty remarkable. Without any need for surgery, a device placed on the scalp generates these very focused, rapidly changing magnetic fields. These fields pass right through the skull and induce small electrical currents in very specific parts of the brain. This allows clinicians to precisely turn up or turn down neural activity for a therapeutic effect. So while rTMS has shown promise for quite some time, its actual clinical usefulness has been a bit of a question mark. Past studies have produced a real mixed bag of results, and that's mostly because they've had small sample sizes and used a huge variety of different stimulation methods. To try and solve this uncertainty, researchers conducted this very large-scale meta-analysis. What they did was systematically pull the data from 19 of the highest quality randomized controlled trials. This gives them a much more powerful and reliable picture of what rTMS can and, just as importantly, cannot do for patients with Parkinson's. All right, so after combining all of this high-quality evidence, what did the analysis actually show? Let's start with the big picture overall results. Okay, this table is where things get really interesting. You can see a very clear pattern. The analysis found statistically significant improvements for 3 key mobility metrics: gait freezing, gait speed, and general motor symptoms. But on the other hand, it found no significant effect on balance or on the total disease score. And this is the exact question that leads us to the most critical finding of this entire study, a finding that could really change how rTMS is used in the clinic. So here's the key insight. The effectiveness of rTMS isn't a simple yes or no question. It all comes down to the specific protocol being used. The study found that there's no single best treatment. Instead, the recipe, that is, the combination of frequency, the brain target, and the session duration, has to be precisely tailored to the clinical goal. So let's break that down. We'll start with the first specific recipe. What's the best protocol if your goal is to improve gait speed? The subgroup analysis was really clear on this point. To improve how fast a patient can walk, the most effective approach uses high-frequency stimulation aimed specifically at a brain region called the supplementary motor area, or SMA. It's this precise combination that produces the strongest therapeutic effect. Now, what's fascinating is that if your goal is different, say you want to improve general motor symptoms like tremor, rigidity, or slowness, well, the optimal recipe is completely different. For these symptoms, low-frequency stimulation works better. The target area also needs to be expanded to include both the primary motor cortex, or M1, and the SMA. And on top of that, a higher dose of stimulation, more than 1,000 pulses per session, was found to be the most effective. Putting them side by side like this really illustrates a central finding perfectly. It's like a tale of 2 different treatments for 2 different problems. High frequency on the SMA improves gait. Low frequency over the M1 and SMA improves overall motor function. The key here is that they are not interchangeable. So why the difference? What's the underlying reason for this? Well, it seems to come down to targeting 2 very different kinds of circuit problems in the brain. So, in Parkinson's, the SMA, which helps govern automatic movements like walking, often becomes underactive. High-frequency stimulation is excitatory, so it seems to wake up this underactive area, restoring the brain's automatic pilot for gait. In contrast, other motor symptoms are linked to pathological overactivity and too much noise in the motor circuits. Low-frequency stimulation is inhibitory, so it helps calm this overactivity, basically improving the signal-to-noise ratio for voluntary movements. So, after all that, what is the most crucial point to take away from this huge and comprehensive analysis? The take-home message is crystal clear. rTMS treatment has to be tailored. A one-size-fits-all approach just doesn't work. To improve gait, you need a specific high-frequency protocol. To improve general motor function, you need a different, low-frequency protocol. Now, of course, good science demands that we acknowledge the study's limitations. The authors are very clear that some of their conclusions, especially those about targeting the SMA, are based on a relatively small number of trials. This means more large-scale research is definitely needed to confirm these optimal protocols before they can become standard clinical guidelines. This research really pushes the clinical conversation forward in a big way. The question is no longer simply, does rTMS work? Instead, it's become, what is the optimal rTMS protocol for this specific patient and their clinical needs? And this shift toward personalized, evidence-based neuromodulation really does raise a hopeful prospect for millions of patients and their families.